Greetings, everyone. Welcome to the 153rd session of the online Optom Learning Series, OOLS. And for today's session, we have with us Professor Nicholas Rumney. Professor Nick is currently in a full scope award-winning practice in the UK. He is a third generation optometrist, graduated from the Cardiff University. And then there is pre-reg at the Bristol Eye Hospital. Further on, completed a master's in low vision in Melbourne. He was also a professional qualifying and fellowship examiner and was one of the handful optometrists of the College of Optometrists member to complete the fellowship by examination. He also has a fellowship by the American Academy of Optometry since the year 1995. Prof Rumney was a part of the GOC team, which is the General Optical Council that develops the regulations for the optometrists in the country and specifically for the therapeutic registration as well. He has been awarded several awards, holds many fellowships and certifications to his credit. And more recently, I think he was also appointed, and he is associated into academics as well with a couple of universities as an adjunct professor and lecturing there. So that's very important. He is also a founding member of the European Academy of Optometry and Optics and recently assumed the presidency of that particular organization. Prof Rumney, outside optometry, I think this is really important, enjoys, he's a car enthusiast and also a rugby union supporter. So I hope I did justice to your introduction, sir. And with that, welcome to our platform. And let me just leave the screen time to you.
So what I'm going to talk to you all about today is the kind of linkage really between the newer methods of assessing structure of the eye and the function of the visual system, particularly in relation to glaucoma. And in the context of structure, it's the actual mechanics of what we're looking at, the nerve fiber layer, the ganglion cell function, etc. And in terms of function, we're thinking in terms of how we assess how we assess visual loss in glaucoma, which is predominantly through visual fields. So these are some new paradigms that just might get you thinking a little bit about where we go. So, oh, hang on. I need to make that slide move. There we go. Okay. So here we have a fundus picture. And what I want to point out to you is that although we are moving into an era of increased instrumentation, the rise of the machine, you might call it, it doesn't replace the clinical decision-making of a clinician. OCT, optical coherence tomography, is now being used in ophthalmology for glaucoma management. In its early days, it was primarily used for medical retina, particularly wet AMD, but now increasingly for glaucoma. And I think that means it's a vital cog in glaucoma decision-making, but not just in terms of management and progression, but also at the detection, which is primarily where many optometrists are working. It has to align with perhaps a different way of thinking about our visual field plots, perhaps the way we've been thinking in the past. And on the basis of that, we'll get new analyses which will come from that different understanding. So first of all, what we have to do is a little bit of revision. We want to think about the structural, that is the anatomical locus or position of glaucomatous damage. And I'm just going to leave that picture on the screen for a moment. You can all make your own mind up at what you're looking at there. We're going to do a brief review of retinal anatomy, especially the retinal ganglion cell and the retinal nerve fiber layer, and a reminder of where glaucomatous damage occurs that you might see on a fundus photograph. So thinking about the anatomy, we're all familiar with this picture that is stylized out of many textbooks, showing the horizontal raphe, showing the papillomacular bundle, and the arcuate projections of the nerve fiber layer. But we have to ask a question. Are all the fovea, are they level with the optic disc? And is the horizontal raphe truly horizontal? And the simple answer is no, the fovea is not always level with the disc. And this is a representation from a paper that looked at a whole series of fundus images undertaken by Choi et al. And this looked at the foveal position relative to the disc. And it basically said that the average disc to fovea angle was something between 6 degrees plus or minus 3.48, so ranging from -1 to 14. So quite a degree of difference. And that was amongst relatively low myopes. It wasn't amongst people with significant staphyloma. So this results in a nerve fiber layer asymmetry, vertical to horizontal. So if you draw a horizontal line across from the fovea, which is typically where our visual field plots are drawn, the raphe may not be exactly horizontal. So let's think about the familiar disc picture. And here's the same optic disc I've been showing you through the earlier parts of the presentation. This is the typical alignment of the nerve fiber layer, the ganglion cells, inner, outer plexiform, etc. And these are the layers that are obviously seen in some detail in OCT. But it has to be said that not all optic discs look like that. They don't all look dead straight and dead square. And in many, there is an angled insertion. You often get myopic crescents because of staphylomatous effects and the angles that the nerve enters the globe of the eye. So here's a couple of pictures taken of a dog's bowl. And if you look directly at the dog's bowl in picture top left, you see it as a circle with a very even shape to the rim. But if you look at different angles and tilts, the rim thickness changes. And of course, it's the rim thickness we're trying to estimate when we're looking at things like cup to disc ratios. And that significantly affects both our ability to observe on the optic nerve, but also it affects normative data, because you have to make sure that particularly an OCT machine, is pulling that data from a normative database that is reflective of the population. We need to relate it to the disc shape and size. And this is why in many instances in OCT scanning in suspect glaucoma, we're tending not to use the optic disc scan. We're tending to use more the macula, which is very often a vertical beam scan over the central macula. So if you think about OCT as a measure of structural damage, the OCT scan is measuring both the ganglion cell layer and ganglion cell complex layer and the retinal nerve fiber layer thickness. It typically describes the macula and the optic disc in a cube of data, otherwise known as a volume scan. And here you can see top left is the fundus photograph. There is a 6 by 6 millimeter square in green with a vertical scan line. And the picture immediately below is the B scan produced by the OCT that is a direct reflection of that vertical scan. Now, if we look at the retinal nerve fiber layer thickness of this particular patient, and is in fact the same patient as the photograph I've been showing you, you can see in the RNFL a significant dark blue arcuate effect. You can also see in the index that the superior average thickness is 26 microns and the inferior is 34 microns, which gives a relative thinning. In terms of the ganglion cell layer, you can see that the oval is slightly notched, and in the ganglion cell plus, that is very much more emphasized, even though the actual numerical difference between superior and inferior average thicknesses are not great. It's a very obvious notch defect, And that's actually very close to the center of fixation. So we tend to pick up the ganglion cell layer in the inner plexiform layer. So that's the two zones from a cube scan. And then we're going to sort of look at that and work out whether that is matching the histological measures. And in fact, in those studies where that's been completed, it does. So let's think about how we go about measuring visual fields. And the most common visual field measurement is usually with a Humphrey VFA, a full threshold technique. And that may be a CETA standard, CETA fast, or a standard program. And it may be either a 30-2 or a 24-2. 30-2 is a very common test. It samples 76 locations described here. And if we think about the grid, it's a 6-degree grid that extends to 27 degrees from fixation. All Humphrey programs that end in -2 are offset from the vertical and horizontal meridians by 2 degrees. Programs 30-2, which use a 6-degree offset by 3. Now, in the standard Humphrey program 24-2, which is cut down, the plots that are omitted are the dark black spots around the outside, except for the pair that straddle the nasal step. So that would be in the temporal field. Nasal field. It will be in the temporal area of the retina. Now, there is another program that comes with the Humphrey, which is called the 10-2. And you can see here the points that are used for the 10-2. And when I was taught my visual fields years ago, and as we first became aware of static perimetry, we were told this was a rarely used test, that it was more for major visual field loss and for progression in the presence of field loss. So really more of an end stage rather than a beginning process. It's a high resolution test that covers the central 10 degrees. And there is the circle of the central 10 degrees. It's a tight 2-degree grid, and it is 1 degree offset from the meridians. There are 68 locations used, so it's quite intense. Now, if we look at the work done by Hood et al., and this is out of Columbia in New York, we're assuming a model here that the axons of the retinal ganglion cells of the superior macula, which is the lower visual field, and the macular papillary portion of the inferior macula, which is the upper visual field, enter the temporal quadrant of the disc. And here you can see the retinal view, and you have the zone that is marked as more vulnerable or outside the macula. So that's the superior macular area. The axons of the rest of the retinal ganglion cell of the inferior macula enter the temporal portion of the inferior quadrant of the disc. And this is thought to be more vulnerable to the disease process. Now, here on the left-hand side, we're seeing a nasal step generated in a visual field plot on a 24-2 plot. And you can see from the blue and the green, the blue and the red, that there are visual field losses above and below the horizontal raphe. But if you actually were to look at that particular retina, there's a 12-degree difference in angle between the superior and inferior. And so you need to think in terms of, well, where exactly does that horizontal line fall? And that creates an artifact. So other artifacts could be the peripapillary scan. So here we're looking at a circular scan, and the little color photograph in the bottom right hand shows you the circle in green. And that shows then above that the expanded B scan of the OCT, And what we're looking for is the separation of the two green lines, and the arrows are pointing to the area in the lower field and the area in the upper field that show what is in effect a notch defect, a thinning of the nerve fiber layer. And that's illustrated in the Nistin plot below. Nistin is nasal, superior, temporal, inferior, nasal. It's going around the circle of the optic nerve. And you may not be familiar with Nistin plots, but that will become a little bit more obvious in due course. Now, some of these nerve fiber layers, these thin nerve fiber layers around that disc scan, can be associated not with the nerve fiber layer itself, but artifacts such as the blood vessel. And the vertical red lines on the graphical representation in the lower part of the field there, in the lower part of the slide, that shows where the red lines might be expected to show that there would be shadows associated with the blood vessels. And so it's important to look to see, are the shadows from the blood vessels where you expect them to be, or are they tilted or rotated out of position? Further work, in summary, from Hood et al. Gives us some clinical implications. First of all, it's been identified that early glaucomatous damage of the macula is actually more common than you might think, that it can be arcuate-like or diffuse, and it's easily missed on the 24-2 because the points don't go very close to the center of fixation. So the suggestion is always that if you've got a hint of suspicion at the optic nerve or in the OCT on the ganglion cell player, ganglion cell complex, or the retinal nerve fiber layer, you should repeat the fields using a 10-2, and probably better still to repeat it on an additional visit. And this is the sort of deviation that you might find on that same patient that we saw a moment ago when you complete a 10-2 plot, that there is significant damage in that area. Ultimately, I guess what will happen is the 24-2 test pattern will be modified to introduce more central points, but that hasn't really happened yet. So what can OCT nerve fiber layer measures tell us about the glaucomatous damage at the macula? And this is actually the same patient that I've been showing you all along, the same color photograph you saw right at the beginning. And this is the standard representation that comes with most OCT machines. It runs from temporal through superior, nasal, inferior, and back to temporal. The difficulty with this is that you don't get very good visualization of the fragile areas, because the fragile areas are the superior temporal to temporal and the inferior temporal to temporal. And as human beings, we tend to look at things that are right in front of us. So if you were to look at that on a different plot, and here we've now represented it on a Nistin plot, we're now seeing that the fragility of the macular area is right in the center, and that notch in the superior temporal area becomes very much more obvious. And there it is. You can see in that optic disc photograph that there is indeed a notch in the neuroretinal rim in the superior temporal zone. And this is a lady, HF. She's a 62-year-old retired teacher. In 2011, we had a very common thing that used to happen here, sometimes still does, and I'm sure you're experiencing it as well, where a GP, a family physician, has misdiagnosed a herpes simplex for conjunctivitis and treated with an antibiotic. So she has a significant scar in her left eye and a resultant cylindrical correction. Obviously, this is the right eye we're looking at here. Now, she went ahead for cataract extraction in 2012, and the hospital eye service, HES, the ophthalmology teams locally, they diagnosed ocular hypertension pre-cataract extraction, finding Goldman pressures at 22, but no visual field loss. And they decided they would put her on Travatan in the lead up to cataract surgery. Following surgery and still on Travatan, there's actually very little drop in intraocular pressure, only to 19. And they decided to discontinue that post-operative Travatan and then put her onto a 12-month monitoring. And of course, she was coming to see us for her refraction, etc. And we just had a few years experience by then of OCT, so we undertook OCT. Once again, at that discharge point, she's no visual field loss. So she's finally discharged in 2014. 2015, when I examined her, her Goldman pressures were still around the 19, 18 millimeters mark. But that is the black and white photograph. And you can see here there is a clear arcuate band of nerve fiber layer loss that stretches directly from that notch defect at 11 o'clock on the optic nerve of the right eye. So I wasn't very happy about that, because we can see that both in ophthalmoscopy, in slit lamp bio, in retinal photography, and in color and red-free. And in fact, the first OCT scan we did showed a ganglion cell defect. And there is the OCT plot. It's giving us on the top right there a linear cup to disc ratio of 0.85. And you can see in the little graphics immediately beneath that, you can see a blue arcuate area in the nerve fiber layer averaging. You can see the redness to suggest that the thickness is thinner than average. And you see the red bands on the cartwheel. Now, this is not red disease. There is, in fact, a nerve fiber layer defect. And if you look at the Nistin plot immediately below, you can also see the notch. And if you're very, very subtle and you look across to the B-scan photograph to the left, this is the gray, the black and white grayscale with the red bar vertically. If you look beyond to the temporal side of the fovea, you can see how that nerve fiber layer dramatically thins. And here is that macular scan I showed you before. This is exactly the self-same patient. So she undoubtedly has a nerve fiber layer defect and a ganglion cell complex defect. But her visual fields, this is the left eye, and we're not actually looking at the left at the moment, 24-2. And that's the left eye, 10-2. We've really no significant defect in terms of pattern deviation. What we're seeing here is a general level of reduction in sensitivity that is more to do with the corneal scarring and the media opacities than it is to do with anything to do with glaucoma. So we can ignore the left eye. But when we look at the right eye, okay, we've got a definite difference when we go and plot the OCT scan onto that plot. And here is the OCT plot for the right eye at 10-2. And you can see how it almost exactly mirrors. Now, we've been using this particular instrument, which is Topcon's swept source, the Triton. And if you look at that, it will create an en face. It flattens everything relative to the inner limiting membrane, and then you can suddenly see the arcuate defect. So we returned the patient back to the hospital, who diagnosed chronic open-angle glaucoma and decided to review blood pressure meds, etc. They did start some aggressive treatment for reducing the IOP, but they haven't told us what the communication was. And I suppose we're all thinking, well, if it's unilateral, will a trabeculectomy be suggested? Upshot is, several years later now, and we last saw her in 2020, just before the pandemic began, that is an absolutely stable retinal nerve fiber layer defect. So I don't actually believe that she has glaucoma. I think she's had a one-off nerve fiber layer defect, probably some vascular event, minor vascular trauma at the optic nerve. And and it's remarkably stable over those years. The only difference between that and somebody with glaucoma is that the glaucoma patient may be expected to have sustained higher levels of pressure. Now, here's another patient. This is patient AM. She's 72. And when I saw her in 2003 for a very first eye examination, it seemed quite routine. Goldman was 15. But she failed the frequency doubling perimetry on an arcuate defect. And we showed a nerve fiber layer defect on red free and in color. So I referred her as a possible normal tension glaucoma, but she developed an ocular surface disease which arose from the non-preservative free xalatan. She was quite unhappy about that and ultimately went to see a private specialist ophthalmologist. We were doing the visual fields in the OCT. And this is her left eye. And you can clearly see in that ganglion cell thickness plot that there is a notch defect there. And you can actually see that in the retinal red-free photograph. There is a very thin, narrow neuroretinal rim at around about 4 to 5 o'clock. So in 2004, we managed to stabilize the tear film with Aquify, which was a branded hyaluronate. And she ultimately went on to have a trabeculectomy, which is commonplace in the UK if you have a low tension, normal tension glaucoma. In 2013, though, I referred her back because we identified a nerve fiber layer defect on the OCT in her right eye. They chose to put her under observation, thinking she might need a trabeculectomy in that eye. And then in 2014, I'd been at the American Academy meeting and I'd been at the Optometry Glaucoma Society that year, and they had talked a lot about the structure function and the linkage between the OCT and visual fields, and particularly the need to think about doing more detailed central visual field testing. So I brought her back for a 10-2 fields, because when we'd referred her with a nerve fiber layer defect, we hadn't got a visual field defect. And then 2015, we acquired the Triton and we brought her back for that. Now that's the left eye, and you've seen the visual field defect in that left eye. You've seen the nerve fiber layer defect in that left eye, I should say. But here you can see she's got a defect very, very close to fixation. In fact, on fixation in the superior arcuate band. So it's not a typical nasal step. It's right close to fixation in the left eye. And that almost directly matches the ganglion cell notch when we've reversed it and inverted it onto the plot. When we do that left eye with a 10-2, it's even more emphatic, the degree of arcuate visual loss to fixation. And there is the same nerve fiber layer plot inverted onto it, so it matches directly. So we're going to conclude there because I've probably raised with you more questions than answers. No instrument or machine does replace your own judgment, and the possibility is that OCT could find you referring ahead of ophthalmology's ability to detect conventional glaucoma. So I urge you to be cautious. Things don't happen very fast in glaucoma often. Go for additional visual field testing, repeat visual field testing, and alternative central visual field plots, so particularly the 10-2. In the UK, in hospital settings, the OCT is usually an ordered image that's booked by appointment. So the patient is given a slip of paper and asked to hand that into the appointments office, and then they get an appointment to come back for their OCT. As optometrists with that right next door to us in the same room or the adjacent room, we don't tend to do that. We just do OCT as a matter of course. It's really important to integrate the structural assessment of the OCT, the fundus image, and the slit lamp binocular indirect with visual fields. And you need to flip that ganglion cell layer plot to match the visual field. And I would say if you get an isolated single point central loss on 24-2, particularly in the opposite field to the disc, then it may be masking a central defect because the plot doesn't sample adequately in the central 10 degrees, and the field plots don't rotate to match that horizontal raphe. So thank you very much for giving me the opportunity to chat to you about this. And I'm sure Fakhruddin has some questions that will come in from the audience, perhaps.
Yes, sir. Thank you so much, for that comprehensive talk. I think this was really important, and the most important and a strong point, I think, is to relate it to other tests. So don't just rely on your OCT. Definitely, it gives you the best image, but relate it clinically as well. So I think that's a very important point you did cover today. Okay, so we do have a couple of questions which have popped up, sir. I'm just going to put that on. The first one here asks about, does the RNFL analysis from the disc and the macula will give the same interpretations in terms of glaucoma, or is it different? So is there any particular...
Okay, so if you take a very average eye, let's say between +3 and -3, a spherical eye of relatively normal dimensions where the fovea and the disc are very close to being horizontally aligned, and you're looking at a relatively horizontal OCT scan when you look at the B scan, the chances are that the information you get from the RNFL and the macula will be pretty nearly exactly the same. You know, if there's a defect in the nerve fiber layer, it will show as a defect in the ganglion cell layer. If it's normal, it will be normal in both. The difficulty comes when you have a more unusually shaped topography of the retina. So, for example, if you've got somebody with a very sloping B scan, what you might see is that the nasal side of the OCT is very sloped, and the temporal side of the OCT is quite horizontal. And in that case, what's going to happen is that the machine is going to think that the nerve is very thin. The nerve fiber layer is very thin on the nasal side, and sometimes the nasal and superior. And of course, what we're saying here is the disc is tilted. So what you may find then is you get a fail and a red sector in the disc. But when you look at the ganglion cell complex, that's more straight on, and you get an absolutely even. And so this is why the choice of of OCT plot that I would always do, if I can't do a 12:9 that gives me both disc and macula in one horizontal position, I would do a 6:6 over the disc and a 6:6 over the macula. And the general view is that if you're doing 6:6 over the disc, it's a horizontal set of scans. And if it's over the macula, it's a vertical set of scans. And some instruments will start to integrate that together, but it's best if you can do a complete plot of the 12:9, because that enables you to judge those. And I'm very, very cautious about errors arising at the disc edge, which give red segments that are, I suppose you could call them red disease, because they're actually normal for that particular patient. So that's a long answer to a short question.
Yeah, very comprehensive, I would put it that way. Another question, I think this is again something very basic, but if you want to give us some important tips on differentiating glaucomatous and retinal defects, so any tips?
This is a really interesting point, because I think the key definition difference here is that glaucomatous is by definition progressive optic neuropathy.
Yeah.
So the biggest single thing that you can do is to keep measuring and keep looking, because if the defect is progressing, so modern OCT machines now have something called trend analysis, so that you can look back on the superior, inferior, horizontal left, horizontal right scans, and you can check whether that is changing over time. Because if you've had a retinal lesion that's given rise to a nerve fiber layer defect, that's gone on to form an arcuate defect because it's damaged the ganglion cell player, then that will be stable over time. Otherwise, it becomes very difficult, because you could have someone who has a visual field defect, who has an OCT nerve fiber layer defect and ganglion cell defect, and it just so happens at the point you make that investigation and you make that discovery that their pressure was 28 millimeters by Goldman. So the assumption is automatically, well, this person's got glaucoma. We'll put them on pressure reducing drops. The pressure drops to 20, let's say, a 30% reduction. And then you look at them again in 6 months, and the visual field and the OCT are exactly the same. And you look at them again 6 months later, it's exactly the same. And you congratulate yourself and you think, I've caught that glaucoma. It's now stable. They're not losing any more vision. But what if that pressure, when you first discovered that, was 14? You wouldn't normally immediately choose to treat that, because it's very much harder to identify normal tension glaucoma. So you would therefore look at the fields and the OCT again at 6 months, maybe another 6 months, maybe another 6 months. And what you might identify there is that this is not progressing at all. So you decide, that must be a vascular lesion at the optic nerve head or on the nerve that's caused that arcuate lesion, and it's stable. The really scary ones are when you've got a low pressure and it continues to decline.
Yeah.
And I think if you've got a high pressure which you're treating and you get continued decline, that's fairly obvious that there is something going on that's glaucomatous. But if you're treating the high pressure and it stabilizes and it doesn't reduce, well, that's a big challenge to the clinician to think about dropping the treatment.
Yeah.
Why would you do that if you think it's working? So I think that's where it's going to become quite interesting as we move towards perhaps more laser intervention with SLT. Because I think then those situations you would probably SLT anyway, and then you'd monitor. But it's all down to the difference between progression or not progression.
Yeah. And just a connecting question to this, the progression analysis. So do you have a system whereby you call in your patients every 6 months, or you want to repeat it every year? Is there something which you follow, or?
Yeah, all of our notes are computerized nowadays. Yeah. So we have a series of default recall intervals.
Okay.
What we don't have is a kind of, I suppose, a chase up. If they don't respond to the first letter that we send them at 6 months, they are sent another letter. They're sent another letter. It goes up to 3 letters. And if they're choosing not to come back at that point, there's not really very much we can do. If they are going to be coming to see us regularly, we generally will sign them up or suggest that they sign up for a care plan. And the care plans are typically an amount of money per month. So it could be anything between 12 to 14 pounds per month that they pay. On the care plan, they get all the necessary appropriate tests. So it means when they come in 12 months' time, we're going to do the Goldman, we're going to do the fields, we're going to do the OCT, as well as any other normal refraction, for example. And the care plan also actually gives them a significant reduction in price of the spectacles, because in all the countries around the world that I'm aware of, always the price of glasses is what is supporting the price of the eye examination, because very few of us can charge how much it costs to actually deliver that chair time.
Yeah.
So if we're getting, let's say, £150 a year because of a monthly payment plan, we can afford to give the patient a 30% reduction in the price of their spectacles, because normally we'd see them once for maybe a £70 eye examination. So it balances out in that way.
That's right. Yeah. But you do want your patients to come every 6 months?
Well, I think you do that on a patient-by-patient basis. So there are some ocular hypertensives where everything seems well controlled and there is no damage, and I would be quite happy to see them at 12 months. Okay. There are some people without any signs of ocular hypertension, but they have a strong family history. I would maybe see them every 2 years. Okay. But I think we have to take into account ethnicity, because if we're dealing with patients from, let's say, primarily Afro-Caribbean background, African or Afro-Caribbean in the UK, they're very much more prevalent and likely to have chronic open-angle glaucoma. But someone from a South Asian or East Asian ethnicity, we have to be very much more cautious about angle closure glaucoma. Okay. And I do think that is quite under-recognized at the moment. And of course, with angle closure glaucoma, it's a real challenge, because the one you want to avoid is the acute event where the pressure suddenly rises. But the only difference between a chronic angle closure and a chronic open angle is the anatomy of the angle. Otherwise, they behave in the same way in terms of their pressure and their disc appearance. That's
right. Yeah. So it's all case-based and the presentation of the patient and ethnicity, correct, of course, right?
Yeah. Yeah.
Okay. One more question is, the company default measures of OCT are the RNFL and the optic region. So do you think that will influence errors when we do the RNFL macula at the macula as well?
So we're not really measuring the RNFL at the macula. The reason you're measuring the RNFL at the disc is because it all bunches up, so it gets a little bit thicker. It's easier to measure. The RNFL at the macula is very thin because it spreads from the fovea anatomically. So when you're looking at macular scans, you need to be looking at the ganglion cell and the ganglion cell complex. So the ganglion cell is the single layer immediately beneath the nerve fiber layer. The ganglion cell complex includes that outer plexiform layer.
Yeah. All right. And one question here. So we are all so engrossed looking at the double hump pattern. I think we were taught in school also, you look at the double hump pattern. So is that something which is not really a thing now, or do we still follow that?
I think it's what I would call a visual artifact. It's what draws the eye to look at a particular thing. And if you're an experienced observer, it's a little bit like saying the experienced observer of a Humphrey visual field plot doesn't look at the grayscale. The experienced observer looks at the numbers. The numbers, yeah. Looks at the mean defect, looks at the pattern square defect, looks at the particular minus figures within the field plot. And I think the experienced OCT user will definitely do just as well with a Tisnet plot as a Nistin plot. But for the naive user, it becomes much more obvious to look and focus on those things in the middle. Okay. That's the difference.
That's the difference. Okay. So can I say that to have a reliable clinical data, we must look at the Nissen plot compared to the Tisnet plot?
I think it just becomes much more obvious to see.
Okay. Okay. So it's much more helpful to see.
Yeah.
All right. So I think with that, so we have taken all the questions which we have, which has popped up on the chat. So with that, thank you so much, sir, for your time and sharing your expertise with us.
Well, that's great. Thank you for inviting me, and I hope that's all gone well for you.
Yes, it was wonderful, and I see some thank you messages already coming up on the chat. So thank you so much, sir, again from the entire team of OOLS and also the attendees for sharing your expertise.
Okay.
Yeah.
Very good.
So Have a good day. We do have session planned on next week. I hope to see you next week. Take care, be safe, and bye-bye.
Bye-bye. Bye-bye.
Thank you, sir. Bye.